Hello from Lake Mendota. We're a little west of the terrace, and so I'm going to bring you today's case of the week. Case of the week today is concerning a 17-year-old white male who presented for a 1-month history of right lower quadrant abdominal pain, which had been associated with diarrhea and constipation. The patient had been seen 1 month earlier by another clinician at my clinic, and at that time he was diagnosed with viral gastroenteritis, treated symptomatically, and sent home. The patient's symptoms had not improved, and he continued to have the same but not worsening symptoms, so he presented to see me for a follow-up. At the time I saw him, he continued to have diarrhea and constipation, along with a 5 out of 10 right lower quadrant abdominal pain. He denied fevers, chills, nausea, vomiting, hematischesia, melena, or mucus in his stools. The patient states that the only other symptom that he had was a 5 to 6 pound weight loss, which he had noted over the past 30 days, and he also noticed some mild dysuria on and off, however denied any unprotected sex. He had had no prior abdominal surgeries, endoscopy studies, or travel outside the U.S. On exam, his vital signs were stable, except for heart rate of 104. Otherwise, his blood pressure was 102/58, and he was afebrile with a BMI of 24. His oral, neck, heart, and lung exam were all within normal limits. On his abdominal exam, noted a flat and soft abdomen with moderate tenderness to palpation over the right lower quadrant. However, there was no mass, rebound, or guarding. Patient did have slight tenderness when I did a heel top, that tenderness being in the right lower quadrant. A genital exam was done. He was circumcised. There were no abnormalities or inguinal hernias noted there. And I did do an anal exam, which noted no fissures or masses. I did not do a digital rectal exam. At that time, he was diagnosed with acute abdominal pain and sent upstairs for a KUB and some lab work. So let's go into the office and see what those results showed. So when he came down from radiology, we pulled up his plain films, and I noticed that he had normal bowel gas pattern throughout. Didn't see any significant abnormalities. However, did notice all of these small white lucencies that are approximately 1 to 2 millimeters in size. You can see them on this film. You can also see them on this film here. Gas here, but you can see those white lucencies here. So walked back into his office, or into the exam room, and I asked him if he'd had anything to eat. Had he taken any medications? He stated that he had taken Pepto-Bismol, which this is consistent with Pepto-Bismol on plain film. This is something to keep in the back of your minds, because you may see that again. His labs returned, with his lab showing the white blood cell count was within normal limits, however, a little bit on the elevated side. Hemoglobin, hematocrit were within normal limits, however, they were on the low side. Significant was his MCV. Normal for his age bracket, 77 to 87. His was 68. With his hemoglobin, hematocrit, and this MCV and MCH, he was bleeding from somewhere. It's just hard to say where it's from. He also had a little bit of a shift. If you look at his neutrophils here, they're a little bumped up here and a little bumped up here. So he has a left shift going on. Got a urinalysis because of the dysuria. Nothing significantly abnormal on his urinalysis. And then also got a BUN creatinine basic metabolic panel. And there was nothing significant on that. So his diagnosis at this time was acute abdominal pain and anemia. So let's go back out to the lake and decide what happened. So after his studies, I presented my plan to the patient and his mother. My differential at that time was between inflammatory bowel disease versus mesenteric adenitis. Kind of explained what I was thinking, kind of explained why I wanted to get the studies I wanted, and explained to them that I would like to get a CT scan of the abdomen. I didn't think it was urgent at that time, as symptoms had been ongoing for the past month. So it was scheduled for two days out, and then they were instructed to follow up with me approximately 2 days after the CT scan. I received a call 2 days right after the patient had a CT scan by the radiologist, who called me in my office here at school and stated that there was significant inflammatory disease. They were presuming Crohn's because it looked like there were some micro perforations. Nothing into the abdominal peritoneal cavity, however, there were some micro perforations. So I went ahead and called up the patient's mother and told her the diagnosis, and was able to get them scheduled with the gastroenterology appointment the same day. They were seen by gastroenterology and started on medication therapy at that time. Last I'd heard, the patient was doing well. As a follow-up, patient's iron studies returned as I was here in my office. His ferritin level was with the normal limits, which you can see on the screen, and his iron returned at 12, which is significantly low, with a percentage saturation of 5, which was also low. So he was bleeding from somewhere, presume his gut. There's some information on the screen right now which talks about Crohn's disease, which is what patient was finally diagnosed with. You can take a look at that, but it does have a bimodal distribution with the first peak age incidence occurring between 15 and 30 years. Hopefully this case was helpful for you and might kind of make you think of a few things when you're in clinic. Thank you.